Emotional damage.
Welcome to Test Day Panic. This is your super fast, focused review for the exam. No fluff, just the critical facts. Let's dive straight into mental health fundamentals and safety.
Okay, core definitions first. Psychosis that's a break from reality. It includes delusions, which are fixed false beliefs.
And hallucinations, sensing things that aren't there.
Right. Now, for delusions, the nursing approach is key. You act based on reality.
Yeah.
Critically, do not play into or argue with that delusion.
Got it. Then there's empathy versus sympathy.
Yeah, empathy, think E for experience. You know what it feels like. Sympathy is more synthetic. You're just imagining.
Then transfer.
Transference is when the patient projects feelings onto you. Countertransference is the other way around. You project onto them.
Okay, safety. Huge topic. Nurse safety first.
Absolutely. Always position yourself between the client and the door. Keep your eyes on them. Maintain distance.
And don't go it alone if you feel unsafe, right? Notify others. Bring back up.
Exactly. For patient safety, you always start with the least restrictive restraints. Always.
And you absolutely need a doctor's order for those. Plus, remove potential harm items.
Use open communication. And don't forget assessment tools like GAD-7, the mental status exam, and especially CAGE for alcoholism. Think trapped in the cage of addiction.
Good mnemonic for psychosis care specifically.
Maintain a positive, non-judgmental attitude.
Right.
Really important. Do not touch and do not argue.
So you validate their feelings, but you do not validate the psychosis itself.
Precisely. You focus on reality. Grounding techniques. Distract them, open-ended questions, maybe describe something in the room, give them a task or puzzle.
What about command psychosis? Hearing voices telling them to do things.
That's an emergency. You must ask the patient what the voices are telling them. You need to know the directive to assess risk.
Okay, shifting gears. Mood, anxiety, personality disorders. Let's start with depression.
Criteria are feeling sad for over 2 weeks, and it's impacting their daily life ADLs.
Symptoms to watch for.
Look for decreased motivation, low energy, definitely increased anxiety, and crucially, increased thoughts of self-harm.
Let's hit the antidepressants. Tricyclics, amitriptyline, doxepin.
Main side effects there are anticholinergic, think drying up secretions, also increased seizure risk and orthostatic hypotension.
Then the SSRIs, escitalopram, fluoxetine, they boost serotonin.
Right, but the risks. Suicidal ideation is a big one, especially early on. Sexual dysfunction is really common.
And they have that slow onset and offset, right? So withdrawal is a risk if stopped suddenly.
Exactly. Then SNRIs, they increase serotonin and norepinephrine. Gives a bit more of a boost for motivation, alertness.
Risks are pretty much the same as the SRIs, though.
Practically identical, yes.
Too much serotonin leads to
Serotonin syndrome. Looks a lot like a bad anxiety attack. Key signs: sweaty, maybe feverish, rigid muscles, tremors, and tachycardia, fast heart rate.
Now the tricky ones, MAOIs, isocarboxazid, phenelzine.
Not used much because of interactions. Big risk. Yeah. Massive increase in blood pressure. And this is super important. Patients must avoid tyramine.
Tyramine.
Yeah.
Think fermented stuff, right? Beer, wine, aged cheese, chocolate.
Exactly. Anything fermented. And you never give MIOIs with other antidepressants. Watch OTC interactions too. NSAIDs, NSAIs, calcium antacids. Also, sadly, an increased risk of suicide.
Good to know. What about non-pharmacological therapy?
Electroconvulsive therapy, ECT, is an option for severe depression or bipolar. It requires general anesthesia.
Speaking of bipolar, that's the one with severe mood swings, highs and lows?
Yeah, the highs is mania, increased agitation, euphoria, racing thoughts. Nursing priority in mania, hydration and nutrition, often overlooked.
Treatment involves therapy and mood stabilizer.
Correct. Now, schizophrenia. You need at least 2 symptoms for over 6 months, and one has to be delusions, hallucinations, or disorganized speech.
Antipsychotics. Typical ones like haloperidol.
Risk of extrapyramidal symptoms, dystonia, Parkinsonism.
And the atypicals usually end in pine or elidine, like clozapine.
Yes, and this is critical. Atypicals can cause decreased white blood cell counts. You have to monitor that.
There's another major risk with antipsychotics.
Neuroleptic malignant syndrome, NMS. Life-threatening. Key signs: high fever, get that cooling blanket. Ice packs, confusion, muscle rigidity, seizures. You must stop the medication immediately.
So let's focus on lithium, the mood stabilizer.
Very narrow therapeutic range. Remember this number. Levels over 1.5 are toxic, critically important.
And the big safety rule is tied to sodium, right?
Absolutely. Kidneys handle lithium like sodium, so you cannot give it to dehydrated or hypernatremic patients. If sodium drops, lithium skyrockets.
So monitor sodium levels constantly. Avoid things that mess with fluid or sodium.
Yes. Diuretics, caffeine counts, furosemide, HETZ, and also avoid NSAIDs.
Signs of lithium toxicity.
Excessive urination and thirst are early signs. The nausea, vomiting, diarrhea. Neurologically, you'll see tremors, confusion.
Got it. Quick hits on other mental health conditions. ADHD.
Stimulants are common. Ritalin, Adderall, manage tolerance with drug holidays, reduce environmental stimuli.
OCD.
Think acrobatic cycle, anxiety, compulsion relief, obsession. Watch for physical side effects like skin breakdown from washing.
Generalized anxiety.
Symptoms like insomnia, stress. Meds include benzodiazepines, better PRN due to drowsiness, and the big one, CNS depression. Buspirone has fewer side effects. Beta blockers can help physical symptoms like a racing heart. And borderline personality disorder.
Emotional instability, impulsivity, often driven by a deep fear of abandonment. Psychotherapy is the main treatment.
Okay, let's transition. Substance abuse and eating disorders.
Addiction. Brain rewiring, dopamine involved. Use isn't a choice anymore. Cycle. Use. Intoxication. Withdrawal.
With alcohol abuse, watch for Wernicke-Korsakoff syndrome. It is a nutritional deficiency, specifically thiamine.
And the treatment is very specific, right?
Yes, this is important.
Right.
Requires 3 doses of thiamine per day for 3 days. Symptoms can include AFib, delusions, hallucinations. Also look for low folic acid and magnesium.
Okay, opioids. What's the #1 danger?
Always remember, opioids cause respiratory depression. Reassess frequently after giving it 15 minutes for IV, 45-60 for oral.
Withdrawal symptoms peak when?
Typically around 72 hours after the last dose. Nausea, vomiting, diarrhea, intense cravings.
Eating disorders. What are the behavioral flags?
Avoiding food, saying they're not hungry, heading to the bathroom right after meals.
Anorexia. How does it differ from bulimia?
The key difference is significantly reduced body weight in anorexia, even the binge purge subtype.
Health risks in anorexia are severe.
Absolutely critical. Cardiac risks due to electrolyte imbalances, especially hypokalemia. Look for prolonged PRQT intervals, palpitations.
And the acid-base imbalances.
Vomiting causes H2 loss, leading to metabolic alkalosis. Laxative abuse causes HCO3 loss, leading to metabolic acidosis. These are test favorites.
Another huge risk, refeeding syndrome.
Yes. Reintroducing food too quickly is dangerous. It needs to be slow, small portions. Remember, bulimia involves binge purge, but they are not underweight.
And binge eating disorder.
High intake, but no compensatory behaviors like purging. Leads to things like hypertension, sleep apnea.
All right, quick shift to immunity and immunocompromise.
Immune function peaks around age 20.
Yeah.
Lowest in the very young and very old. Skin's your first defense line.
Types of immunity?
Natural active, get sick, lifelong. Natural passive, mom to baby, temporary. Artificial active, vaccination. Artificial passive, antibody injections like IgG.
Key immune cells.
Neutrophils. Phagocytic, they eat invaders. Short-lived, fast responders. Monitor the ANC absolute neutrophil count. That's vital.
Vaccines.
Also phagocytic, but long-lived. They release cytokines, those chemical messengers.
Antibodies. The mnemonic.
MGE, GED, MGE. M is first. A in secretions, like breast milk. G is most common. E for allergy. D is least important for now.
Cell-mediated immunity. T cells.
These CD4 helper T cells are crucial. They activate other immune cells, release cytokines. They're what HIV targets.
And natural killer cells.
Important. They're cytotoxic, meaning they kill infected cells, but they do not need flagging by other cells. Super important in conditions like HIV/AIDS where other signaling is down.
Okay, immunocompromised care plan. Neutropenic precautions in the hospital.
#1 priority, hand hygiene. Cannot stress that enough.
Specific precautions.
Absolutely no fresh flowers or plants. Full PPE for anyone entering. Food must be fully cooked. No open-top water containers. Pitcher water is only good for 1 hour.
Pneumonia prevention.
Turn, cough, deep breathe. Limit visitors, especially no visitors with recent active vaccines or any illness.
Protecting entry points. Central lines.
Prevent clap baths. Central line-associated bloodstream infection. Use aseptic technique. Scrub the hub vigorously. Remember, the biopatch maximum duration is 7 days.
Vitals are different too.
Yes, a temp of 99+ degrees Fahrenheit is significant. They don't mount a high fever like healthy people.
Any meds to boost white cells?
Vilgrastim stimulates WBC production, but it takes time, 2 to 4 weeks, to really start working.
What about precautions at home? What should they avoid?
Okay, big list. Avoid gardening, landscaping, mowing. No tending to pets or kids if possible. Diapers, litter boxes. Avoid crowds, public places. No sharing food or utensils.
All right, autoimmune, allergies, anaphylaxis, lupus.
Affects connective tissues. Common symptoms. Overwhelming fatigue and that classic butterfly rash.
Key trigger for flare-ups.
UV light sensitivity. This is huge for patient teaching. Must protect themselves from sun and UV exposure.
Who gets it most often?
Mostly women in their 20s. And frustratingly, there's no single definitive test for lupus.
Rheumatoid arthritis.
Causes overall joint stiffness, attacks synovial joints, big risk, pathological
Here's
fractures,
the classic symptom.
stiff joints, especially bad when they first wake up in the morning.
So patient teaching includes morning stretches.
Definitely. Morning stretches and exercises help a lot. Treatment for both lupus and RA often involves DMARDs and steroids.
Allergies and reactions.
Type 1 hypersensitivity is IgE-mediated, fast onset under an hour, leads to anaphylaxis. Type 4 is T-cell mediated delayed onset.
Most dangerous, immediate reaction.
Angioedema. That swelling, especially around the face and throat, can cause airway obstruction, life-threatening.
And anaphylaxis itself.
Full body vasodilation.
Yeah.
Leads to severe hypotension, compensatory severe tachycardia, laryngospasm, the airway closing up.
Treatment priorities for anaphylaxis, step by step.
Okay, this sequence is critical. 1, stop the exposure to whatever caused it. 2, EpiPen immediately. Don't hesitate. 3, sit the patient up, helps breathing. 4, assess vitals, especially O2 sats. 5, call for help rapid responder provider. 6, oxygen high flow, 100% non-rebreather mask, crank it up. 7, then other meds, more epinephrine maybe, IM preferred or racemic, antihistamines like Benadryl, steroids.
Using the epinephrine pen specifics.
Orange to the thigh. Hold it there, then massage the site after. If symptoms don't improve in 5 minutes, you can give one more dose.
And after using it,
They must go to the hospital, absolutely essential. The epi wears off, but the allergen might still be in their system. You can give it through clothing.
okay. Chemotherapy quick points.
Chemo is often a vesicant, meaning it damages tissues. It must be given through a central line as possible to avoid extravasation. All waste is hazardous special biohazard box.
Bone marrow suppression effects.
3 big ones. Anemia, low red cells. Thrombocytopenia, low platelets, so no NSAIDs, soft toothbrush needed. And leukopenia, low white cells, triggers neutropenic precautions.
Also reproductive risks.
Yes, potential damage. Patients may want to consider preserving sperm or eggs before starting chemo. Important discussion.
And a complication of rapid cancer cell death.
Tumor lysis syndrome. The cells burst open, dumping contents into the blood. High potassium, high phosphates, high organic acids can cause kidney failure, arrhythmias.
Medications for autoimmune, again, corticosteroids. Prednisone.
They provide bridge therapy, give rapid symptom relief while waiting for the DMARDs to kick in, which can take like 4 weeks.
Stopping steroids.
Must wean off slowly. Stopping abruptly risks adrenal crisis and circulatory shock. Big side effects too. Hyperglycemia, osteoporosis long-term, insomnia, weight gain.
Methotrexate, first-line DMARD.
Folate antagonist. Side effects. Bone marrow suppression again. It's highly teratogenic, absolutely contraindicated in pregnancy breastfeeding. Causes alopecia, photosensitivity,
Interactions.
severe reactions with NSAIDs. Patients need folic acid supplements to reduce side effects and avoid live vaccines while on it.
Hydroxychloroquine. Another DMARD.
Key side effect. Retinopathy, blurred vision, requires eye exams roughly every 6 months. Also, limit sun exposure.
Monoclonal antibodies. The MAB drugs.
Also, DMARDs, they carry a black box warning. Increased risk of serious, potentially fatal infections, especially if combined with other immunosuppressants.
Final section. HIV/AIDS essentials.
Okay, acute infection starts about 2 weeks after exposure, often just flu-like symptoms.
When does HIV become AIDS?
The official AIDS diagnosis happens if the CD4 count drops below 200 or if the person develops an AIDS-defining condition.
Examples of those conditions.
Pneumocystis jirovecii pneumonia, PJP, only really causes pneumonia in immunocompromised folks. And Kaposi sarcoma, those purplish lesions, often look like a bruise, typically starting in the mouth.
Goal of treatment.
Get the viral load to undetectable, basically 0.
Antiretroviral therapy.
RT usually requires 2 to 4 different drugs working together. Compliance is everything.
Why is compliance so critical?
Because missed doses allow the virus to replicate, and lapses in therapy compliance will likely cause viral mutation and drug resistance. It's a huge problem.
Prophylaxis options.
PrEP. PrEP is pre-exposure prophylaxis, ongoing daily medication for high-risk individuals to prevent infection.
And PEEP.
PEEP is post-exposure prophylaxis, used after potential exposure. Must start within about 72 hours of exposure. It's a 28-day course of ART meds.
Wow. That was a massive amount of critical information delivered fast.
It was intense, but hopefully hitting these high-yield points helps solidify them right before your exam.
Any final thought for our listeners?
Just try to integrate these concepts. Think about the connections. For example, the medication safety points we covered are complex. So here's something to ponder. Considering things like the MAOI tyramine rule versus lithium's dependence on sodium levels, how will you build your mental checklist during MedPass to ensure safety across all these different patient needs and drug interactions?
Great question to take into the exam. Good luck, everyone.